topic of my talk is echocardiographic assessment of mitral valve prosthesis. So this is a brief overview of my talk. I would discuss about the key points in the echocardiographic evaluation, then the normal Doppler parameters of prosthetic mitral valve, and then we'll discuss the different etiologies for elevated peak velocity and mean gradient. And finally, with the examples, we'll discuss or evaluate the prosthetic mitral valve. So while doing the assessment of prosthetic mitral valve, the things which are very important before starting the echo is the clinical history. The clinical history is very much important, and we should know about the presenting symptoms, whether the patient is presenting with shortness of breath, or whether the patient is presenting with decreased blood pressures, or with fever, or maybe with suboptimal INR. So these things are very important before starting the echocardiography. Similarly, the baseline study, if it's available, then it's very important, because then you would like to compare the new findings with the previous study, and that's very important, especially in patients with patient prosthesis mismatch. And if you know the type and size of the valve, it's also important, because different valves have different gradients, and while doing the echo, you must check the blood pressure and the heart rate, and must measure the height, weight, and calculate the body surface area. Attention should be given to the flow states, whether the patient is anemic, or whether the patient is having fever, or high flow state like pregnancy or thyrotoxicosis. And now, starting with the 2D echo, the point which is important while starting the 2D is the opening and closing of the leaflets or the occluders. So we should focus on the opening and closing of the leaflets, and then look at the abnormal densities which may be attached to the valve, which may be thrombus, which may be pannus, or the vegetation. So coming to the Doppler parameters of prosthetic mitral valve function, the peak velocity should be less than 1.9, and the mean gradient should be less than 5 in each and every case. If it's more than that, then you can suspect the possibility of abnormality. And if it's like peak velocity is more than 2.5, then clearly it would be abnormal. And if the mean gradient is more than 10, then clearly it would be abnormal. So if you have find, the increased velocity and the raised mean gradient, then what could be the cause? So these are the different causes of increased velocity or mean gradient. Number one is the pathological obstruction, which may be because of thrombus, maybe because of pannus, or maybe because of degeneration. The other possibility of increased velocity and gradients is functional stenosis. That's the valve is normal, but the flow is increased either because of the high flow state, because of anemia, because of tachycardia, or the valve is otherwise normal, but that valve is smaller for that body surface area, and that is called patient prosthesis mismatch. Or the third possibility of increased velocity and increased gradients is the prosthetic valve regurgitation, which may be valvular or paravalvular. So how would you differentiate among these different conditions? The next thing after taking the peak velocity and the mean gradient is the pressure half time. If the pressure half time is more than 130, then likely it would be secondary to pathological obstruction. If the pressure half time is less than 130, then it may be patient process mismatch, or maybe high flow state, or maybe regurgitation. So this is a good chart for bioprosthetic mitral valve assessment. So if the pressure half time is less than 130, then it may be because of pathological regurgitation, or patient prosthesis mismatch, or tachycardia or high volume state. And in that case, you have to then check the DVI or VTI ratio. If the VTI ratio is more than 2.3, then you would suspect regurgitation. If it's less than 2.3, then it may be patient process mismatch or high flow state. And in that case, the effective orifice area index is very important. If it's less than 1.2 centimeter square per meter square, then it's likely patient prosthesis mismatch. So these are the examples. These are the two patients. Both have 29 millimeter porcine mitral prosthesis. Both patients have E velocity 2.3 and mean gradient of 9. But the pressure half time in case 1 is 139, while it's 51 in the patient 2. So in patient 1, it's likely pathological obstruction, while in patient 2, it may be tachycardia, or maybe patient process mismatch, or maybe regurgitation. And then we calculated the TVI ratio. And in this case, the TVI ratio is 2. So it's less than 2.2 or less than 2.3. So it's likely high flow state or patient process mismatch. Then we calculated the effective orifice area index. And in this patient, it's 0.73 centimeter square per meter square. So this is a case of patient processes mismatch. The next case is a 45-year-old woman with prior history of bioprosthetic mitral valve replacement and now presented with worsening shortness of breath. And starting with the 2D examination, if you focus on the 2D, you can see that the leaflet is clearly abnormal. So the mobility of the leaflet is clearly abnormal. This is maybe flail leaflet. And then you see the Vmax is 2.6, mean gradient is 7, but the pressure half time is 121. So it's less than 130. And the DVI is 3. So it's likely mitral regurgitation as the abnormality. And the things which are favoring it is the leaflet morphology or leaflet mobility as well as the DVI. So when you put the color, you can clearly see that there is significant mitral regurgitation. In some cases, when it's difficult, you can take the help of transesophageal echo or 3D echo as well. And especially in patients with mechanical valve, it's difficult to pick up the MR, then you have to go for transesophageal echo. So this chart is important for mechanical mitral valve prosthesis. Again, it is similar to the other one, but the TVI ratio cutoff is less than is 2.2 rather than 2.3. So coming to the mechanical prosthetic valve, this is an example of a 30-year-old woman, status post mechanical mitral valve replacement, presented with cardiogenic shock. And here you can see the 2D examination that the valve mobility is very much restricted and there is something probably sitting on the valve. And if you see the Vmax is 2.9, if you see the mean gradient is 27, and if you see the pressure half time is more than 250. So it's not 130, it's more than 250. So it's likely pathological obstruction. And again, the chart which I showed you before, pressure half time when it's more than 130, you would suspect obstruction, pathological obstruction. So in this case, you can see the MR is not significant, but if you focus on the 2D image, there is a thrombus sitting on the valve. So this is the stuck valve. Whenever there is a stuck valve and you are not sure about the thrombus, you can take the help of transesophageal echo, or maybe you can take the help of fluoroscopy, or maybe CT angio. The next case is a 52-year-old woman. She had MVR with mechanical prosthesis in 2019 and presented with NYHA2 symptoms. And here the peak velocity and the mean gradients are elevated, but the pressure half time is 108. So there is likely no pathological obstruction. And the TVI ratio is 1.9, so likely no MR. So if we see the effective orifice area index is 0.67, so it's patient processes mismatch. So patient, if the valve area is less than 1.2 centimeters square per meter square, then it's patient processes mismatch. And the patient who is having patient process mismatch would behave like mitral stenosis. There will be persistent pulmonary hypertension, there will be poor exercise tolerance, and there will be poor long-term survival. So this is the study which is showing a poor outcome with severe patient processes mismatch. And how can we prevent that? You can, calculate the body surface area, then multiply it with the 1.2 and compare the results to reference values of effective orifice area for the processes being considered for implantation, and it should be greater than this value. So coming to the next case is a 32-year-old man, status post DVR in August 2022, now with fever and worsening shortness of breath. And here you can see on the 2D image on transverse echo that there is probably something attached to the mechanical valve. If you see the Vmax, it's 2.1, the mean gradient is 7, and as there was possibility or suspicion of something attached to the valve, this patient also underwent transesophageal echo, and the lower image is actually the transesophageal echo image, and here you can appreciate that there is clear-cut, vegetations there. And in this case, the pressure half time is 85, and the VTI ratio is 2.4. So likely mitral regurgitation. And on these images, you can appreciate that in addition to the vegetations on the mitral valve, there is paravalvular mitral regurgitation, which is causing increased DVI ratio. So clearly you can see not only the vegetations, large vegetations, but also the paravalvular MR. So in summary, while doing the evaluation of mitral prosthesis, the key points which I described you are important while doing the 2D examination, and even before starting the 2D examination, the things are important like history and other things. And when you start and you see that the E velocity is more than 1.9 and the mean gradient is more than 5, then it signals that something may be wrong. And then you have to see the pressure half time. If pressure half time is prolonged, then likely pathological obstruction. If it's not prolonged, then again maybe MR, maybe patient process mismatch, and maybe high flow state. And then VTI ratio would help you in differentiating among these conditions. If VTI ratio is elevated, then likely MR. And then differentiating between high flow state and patient process mismatch, the effective orifice area is important. If it's low, then it's likely patient processes mismatch. And remember that in case of pathological obstruction also, the VTI ratio would be increased and the effective orifice area would also be reduced, but you can differentiate it mainly from the raised pressure half time. Thank you very much.
Thank you, Dr. Tipoo, for finishing well in advance of your regular time. Before anybody else could ask, I would just like to say a few words. Dr. Tipoo has mentioned this algorithm which he was talking in his book as well, which is available in the market. And I have found it very, very helpful. If you follow the algorithm, you can pick up cases where there is something wrong with the mitral valve. So now for the questions, please.
I'm Dr. Shajil. I'm a big fan of your teaching. I have a question regarding paraprosthetic leak. We've been doing transesophageal echoes routinely on paraprosthetic leaks for mitral valve, but I would like your take on it. What measurements do you prefer in context of percutaneous repair, device closure of the paraprosthetic leak? Do you prefer 2D measurements or 3D measurements for that? And how do you size the device and what devices do you use?
Okay, I have very limited experience about that. First of all, I would say this thing. But the paravalvular MR is, mostly picked up on transesophageal echo, and especially in patients with mechanical valve. And 3D echo is basically the best while doing the, percutaneous, device closure of paravalvular leak. Then 3D echo would be rather more helpful than the 2D echo, because then you can measure the actual size and you can guide the interventionist about the closure of that leak.
Thank
you. Yeah, if I may.
No other question? Oh, Dr. Abubakar.
Yeah. Tipoo, I don't understand why in this era of sophisticated echo, CT and MRI, preoperatively, patients would develop mismatch. Does not the surgeon look at the site of where the valve is going to be replaced and correlated with his judgment, visual judgment, and correlate that with the echo in CT and MRI?
Well, before Tipoo could answer, I welcome General Wasim here, who is the cardiac surgeon, and I think he could answer better your question.
Because it's related to surgeons.
Wasim, please go to there.
Sir, when we do the mitral valve, the valuation is there. The echo is the fundamental tool that is used for the evaluation of the mitral size. The size generally, it's mentioned 43 millimeter or whatever, and generally we know what is there. But when we do the operation, there are sizes available. You cut the valve, or if you don't cut the valve, you size the annulus first. And I think in this era, this patient process mismatch should be there. But mind you, when you do the redo surgery and when you take out the valve, the annulus is thick, it is fibrous. You leave some part of the cloth which is with the old valve there, So what happens? Then you have the difficulty in taking out that part of the valve. Then it becomes thick. Then that is the technical point where some surgeons, while doing the redo surgery, they prefer to put a small because of the technical problems. That's what happens generally in the redo surgery. In the pristine mitral valve surgery, this prosthesis mismatch should not be there.
So
Thank you, Doctor.
there may be another possibility that patient may, size of the patient may grow, the body surface area may increase, the obesity may increase. So that may also lead to patient process mismatch in the late in the life.
Yeah.
So this is another possibility. Yeah.
Generally, I mean,
Yeah.
if you have the a very small patient, a young patient like the in early age of the ladies which present, and you want to put these the biological valves. So these things can arise, but when you at first pristine mitral valve surgery, these things should not happen. And most of the time, unless you have pediatric population, that is something different. But in adult population, mitral valve area compared to the body surface area, it should not happen. And likewise, in the aortic valve surgery, when you are planning the surgery, this thing should not happen again, because mitral valve area extrapolated to the body surface area. That is the key to the for the prevention of this patient prosthesis mismatch.
Thank you, Dr. Vaseem.
Thank you.
Salman, please.
There
Quickly, we
are,
are.
I would like to indicate that there are a few caveats in the measurement also. For example, the recommended ways to some of the studies mention a mid-diastolic measurement of the for measuring the mitral annulus. There are other studies which indicate an end-diastolic measurement, and there are some other studies which indicate that you should measure the annulus in a four-chamber view. So what I am trying to say is that there may be a difference in measuring rather than the fault of a surgeon.
Agreed.